All right, now this biomechanical analysis isn't going to be due until like, I think, week 13. So don't worry about that. It was like last year we had this a lot earlier in the term. So I just didn't change the PowerPoint, but whatever. So don't worry about it so much yet, but it might be something to start thinking about, especially because you have to do, or did you already do your biotech paper in lab? Okay. So we'll talk more about that later on. Now, wrist and hand, and I believe, are you all on what, the hip now?
Yes.
Okay. So yeah, you're roughly 1 week ahead. So hopefully most of this is review for you here. Now, with the wrist and hand overall, tons and tons of stuff, a whole lot we're not really going to need to know or focus on, just because it's really outside of our pay grade. Things like, say, like your intrinsic muscles of your hands, things like that, really important if you're like, say, a hand therapist or an occupational therapist. Not so important when you're, you know, an undergrad kinesiology student. So I want you to know more of the basic movements and structures as opposed to all the minutia behind that. Primarily, you're only going to have 2 degrees of freedom with virtually everything in the wrist and hand. So wrist, flexion, extension, radial and ulnar deviation. While you can kind of circumduct your wrist, it's really not true circumduction. The only time you can actually circumduct for real is when you can rotate. You can't rotate any of your wrist joints. So because they're ellipsoid, they'll give you this movement, but all it is just a combination of your flexion, extension, and your radial ulnar deviation. Not like, say, the shoulder, hip, even, where you have that transverse plane movement, so you can get that true circumduction out of it. Now, what's the mnemonic you guys all use for remembering the carpal bones?
I don't think it was very appropriate when I came up with it last year.
So it's probably the one I'm thinking of. So yeah, the one I used always was some lovers try positions that they can't handle. I forget, someone on Wednesday said a much more appropriate one. Forget what that was though. Is that the one you were thinking of?
It is something like that.
Okay. So for this here, they're going from left hand palmar view, so facing you like that. You're starting on the proximal end, ending on the distal end. So that's where you get your, or where you can actually feel it. So if you start at your thumb and you go straight down to the base of your thumb, and then you feel where it kind of digs in, and then there'll be like a nice little bump there, kind of right parallel with where your first kind of fold is on your wrist. That there is going to be your trapezium. If you go right below that, that's where you're going to feel your scaphoid. Now, your scaphoid is not going to be the same thing as the distal end of the radius. So if you feel on the wrist itself, if you look for your anatomical snuff box and then go, there's a ligament here right below that, that's really where your distal radius is going to be. So it's going to be inside or more anterior to that. The pisiform, you're going to feel if you go from your pinky straight down, and then you'll feel on the very end here, that's going to be the triquetrum. If you were to, like, say, push your finger inward, you can kind of feel the hamate. Right below that triquetrum, that's where you're going to feel your pisiform. So little notch sticking out, not the one that's on top. So the one that's on like the kind of side here. So make sure you remember these. You should know the distal radius and ulna. Now, the actual wrist proper is made up of your radiocarpal joint. So the radius and your carpal bones are what makes up the actual wrist itself. Remember, the ulna is fixed, so the ulna is not going to do really much movement at all for the wrist. It's primarily just going to be your elbow flexor extender. You don't really have any major connections between the ulna and your carpal bones. Now you do have a distal radial ulnar joint that still is going to do that same pronation supination, but your ulna doesn't really do anything in terms of movement of the wrist. It's primarily all done on the radius. So the radiocarpal joints are all ellipsoid. And again, those ellipsoid joints have 2 degrees of freedom: flexion extension, radial ulnar deviation. So sagittal frontal plane movement, no transverse movement. Radial ulnar joint has transverse plane movement, but that's it. Other joints to remember: the CMC joint, or your carpometacarpal joint, that's the joint you have for your thumb. So your metacarpal bones are all in your palm, and those don't move at all. I mean, I guess if you could actually like bend or fold your palm over on itself, that would be either really impressive or really scary. But your CMC joint is actually down kind of at the base here of your thumb, and you can actually move that. So that's why it's special. But it's also because you don't have that third knuckle for your thumb. That metacarpal bone kind of acts as that, or that CMC joint kind of acts as that third knuckle. So when you actually see like the pad of your thumb moving, that is what's signaling that CMC joint moving. The MCP joints were your first knuckles, and then your pip and dip muscles, or pip or dip muscles, your pip and dip joints, so proximal and distal interphalangeal joints. Now, I wanted to kind of bring this to your attention real quick, because I'm sure if you have looked at the lab, you'll notice kind of some discrepancies here. So yeah, even just from the lab to lecture, your normal ranges of motion are different. Pretty much whatever source you use, you're probably going to get something that's a little bit variable to it. So for example, this here says pronation and supination 70 and 85 degrees. Lab says that they're 85 to 90 degrees. I'm not so concerned if you say, you know, pronation has 90 degrees as normal range of motion. I would be more concerned if you said it had something that's way off, like 50 degrees or something like that. So just know that the norms are going to change based on what source you use. I know if you take any of the athletic training classes, I think it's athletic injury, maybe, they have different ones there too. So it's a little hard to get unified on that front. So just know that you do have, based on the source, different normal ranges of motion. Don't let that bother you too much. As long as you're in the ballpark, you're gonna be okay here. Oh, and again, while pronation and supination is listed as a wrist movement, remember this is going to be proximal to the wrist. Your distal radial ulnar joint is before you have your radiocarpal joint. So yeah, it's in the area, but it isn't technically part of the wrist proper. So don't let that confuse you, because pronation, supination definitely is a transverse plane movement, but it doesn't fit with the wrist being an ellipsoid joint, which wouldn't allow for transverse plane movements. So hopefully that doesn't confuse you too much. All right, your TFCC is really the only cartilage you need to kind of remember for this. And it's just because that this is kind of similar to, like, say, your meniscus in your knee. It's really the thickest cartilage you have in the upper extremity. And it's the really biggest one you have as well. What this does here is this really protects your radius and ulna from everything else. What's also unique about this is that you have a lot greater vascularization of this, so meaning you have a lot more blood flow to it. Now, all cartilage is going to degenerate at some point. I mean, you live long enough, your cartilage is going to break down. That's why you don't see, 100-year-olds running marathons kind of thing. I mean, if you make it to 100, just be happy with that kind of thing. But like I said, what's unique about this is that it's cartilage with vascularization, meaning that it has a lot easier time healing itself than other areas of cartilage would. So like your labrum, your meniscus, those are largely avascular. So if they get injured, they're, you get surgery or you live with it kind of thing. With this, it'll actually heal itself to a degree. I mean, if you completely ripped it off the bone, it's not going to, magically fix itself. But any kind of basic little injury to that is going to be repairable on its own because it's vascular. All right, your intercarpal joints, these here really don't do a whole heck of a lot of movement. These are just going to really contribute to the movement of the radiocarpal joint itself. All right, your CMC joint is the actual saddle joint that you would think of with the thumb. A saddle joint is really like a joystick. Or if you play any video games, if you have the joystick things on your controllers, that's the exact same thing of what a saddle joint does. Again, it has a whole lot of movement to it, but you don't have transverse plane movement. So you can't twist your thumb, at least voluntarily. These, the carpal metacarpal joints, these ones here are going to be bridging between the distal end or the first row of your carpal bones and your proximal metacarpal bones. So these are going to contribute again to flexion extension, but they're not doing really anything on their own. Phalanges or fingers, great. Now, when we talk about the muscles here, we'll see that all the muscles just pretty much are named after whatever they act upon. So they tell you exactly really where they are and what they do just by the name itself. Now, when you refer to any of your digits, you're primarily talking about your fingers, not your thumb. So your thumb is usually separate from this. And it's just because you have a different set of musculature that kind of governs it, kind of thing. With your fingers, 3 joints we have: your MCP joint, your proximal interphalangeal joint, distal interphalangeal joint. Fingers are all condyloid, so they're essentially a less functional saddle joint. So what these will do is your flexion extension and then ab adduction. Now, when you have ab or adduction with the fingers, you're talking about using them relative to your middle finger. So your middle finger is midline in terms of the frontal plane reference for your plane of movement. Meaning if I spread my fingers out, that's abduction. So I have middle finger here, my index finger goes this way, my pinky finger goes that way. Both of those are abduction, even though they're moving opposite directions. Bring them together, adduction. I guess you kind of would have to abduct your middle finger no matter which way you went, but I don't know how many of you are doing that kind of thing. Most movement you have with these are in flexion. You have the least amount of movement in extension. And if you think about it, you really don't need a whole lot of finger and or wrist extension to do a lot of the stuff you would normally need. I mean, if you can keep a neutral wrist, everything you really need to do in terms of, like, say, ADLs or even functional living is all in flexion. I mean, grasp something, flexion. You know, if I have to position my hand somewhere, I really just need flexion. Extension isn't really all that beneficial for you. I'm trying to carry something, wrists are in flexion. You don't usually extend your wrist to carry something. So extension really not all that important. I mean, yeah, I definitely want to have it if I can, but if I don't, I mean, I'm not losing sleep over it, kind of thing. I mean, I say that now, but. We'll see when we do the foot and ankle, how you have very little individual control over your toes, which I don't know how many of you can move an individual toe while keeping the others not moving. You kind of have that same problem to a lesser extent with the fingers. So, like, yeah, I can move my fingers independently of each other, but because they all share really a similar network of tendons coming, you know, through them, that individualized motions can sometimes get a little tricky, especially when you're talking about using, like, say, the middle and ring finger. So, like, for example, if I bend my ring finger, I can do that, but how well can you say bend? How did I do this? Oh, yeah. So if you hold up 4 fingers and then try to put your ring finger down, how well can you do that without moving any of your other fingers? Kind of thing. And then try to do that with your middle finger now. And you see what happens to your ring finger when you do that. So we'll see in a couple slides that the tendons actually kind of cross over each other. So you actually have several of these that are going to move or cause movement amongst a few different fingers at the same time. This makes it more difficult to really voluntarily move a digit independent of another one. And there it is right there. All right, thumb movements. Remember, these are different because the thumb's all different. So with your thumb, you can't really, I guess, place your thumb in your typical anatomical position, use that as your reference point. Because when I move my thumb, abduction is going away from my hand. So you're using your hand as really your reference point. Anything in front of that is considered abduction. Adduction is just really coming back or repositioning it. So if you look, reposition and adduction are really the same thing. Your extension is making the L. Flexion is when you cross over or try to touch your palm. And then opposition is just being able to touch your thumb to your other fingers. So this is what sets, primates apart from the rest of the animal kingdom, is this whole thumb opposition. You wouldn't be able to have fine motor skills if you didn't have opposable thumbs. So don't let the thumb movements confuse you there, but just remember that the thumb movements are different. The ones you should remember: abduction, flexion, extension. All right, any questions on the bones and joints? Great, so let's get into the muscles here. Keywords you're gonna have to remember, or you should know, we'll describe everything here. Carpi refers to your wrist. Radialis ulnaris refers to radius and ulna. Extensor, flexor, kind of self-explanatory. So all of your wrist flexors, extensors are going to contribute to both your sagittal and frontal plane movements. If it's a flexor or extensor, that tells you which sagittal direction it moves, and whatever bone that it connects with tells you what frontal plane movement it goes. So radialis is going to do what in the frontal plane? Yeah, there you go. So radialis moves thumb side, radial deviation. Ulnaris moves pinky side, ulnar deviation. So if something says ulnaris, you move towards your pinky side. If something says radius, you are moving towards the radial or thumb side. Have you done the first lab practical yet? Okay. How'd that go for you all?
Not graded yet.
Do what?
That's not graded yet.
Oh. Did you do it this week?
Last week.
Oh. I mean, if you did it last week, that should already be graded. But oh well. All right. This here is the medial epicondyle of my elbow. What other structure is there that I need to worry about? And this is an anterior view too, so you're looking at it this way. All right, so first off, what?
I was going to say carpal ligament.
No. Elbow. All right, so first off, where's your medial epicondyle at? All right. Other than muscles and tendons, what else is there that we talked about?
MCL of your elbow, basically.
Your UCL.
UCL.
Ulnar collateral ligament. This is going to tell you why the UCL potentially has so much strain on it. It's because your insertion point, well, I shouldn't say insertion, your origin point of all of your wrist flexors are going to be at or around the UCL. So if you ever see like a baseball pitcher that complains of forearm pain, and then all of a sudden they need Tommy John surgery, it's because of this. Remember that your UCL is that kind of a triangular type ligament. So it has to hold all of these really in place kind of thing. And it just makes it for a very tight fit. Your wrist flexors are going to be much stronger than your wrist extensors. So when you're using these, you're placing a ton more strain on the elbow, especially the medial elbow, than you would with the lateral elbow in relation to your wrist extensors. I mean, think about it. If you're doing like, how many of you have ever done like wrist curls before? All right, and what's easier to do, the forward curls or the reverse curls?
Forward.
Yeah. Roundabout, on average, you can lift about 2 to 4 times more with wrist flexion than you can with wrist extension. It's just your extensors are not nearly as strong as your flexors. And in general, flexion is the position of deformity for your body. So you think of like, say, you know, you curl up in the fetal position kind of thing. Flexion, for the most part, tends to be the motion that carries the most amount of functional use and is usually the strongest movement you really have. There's a couple exceptions to it, but for the most part, your flexors all over your body are usually going to be stronger than your extensors. The only real big exceptions to that are going to be like, say, your hamstrings relative to your knee and your triceps relative to the elbow. Yeah, so that's really about it. Yeah. So anyways, with all of your extensors and flexors, they are all going to say extensor or flexor on them. Now, keyword we have for the fingers is going to be digit. Anything that says digit on it refers to a finger moving muscle, which does not involve the thumb. Thumb's keyword is pollicis. Don't confuse it with hallicus, which is your big toe. But if you see digit, it's a finger. You see pollicis, it's a thumb. You see carpi, it's your wrist. Anything in Latin refers to your body. Anything in Greek refers to a disease. All right. With your finger flexors, remember, don't worry about the intrinsic muscles. But in general, when you have any really muscle group and talk about them in terms of their depth in the body, the deeper the muscle, the more distal it's going to act. The more superficial something is, the more proximal it's going to act. So in the case of the fingers here, Yeah, here, for example, flexor digitorum superficialis and then flexor digitorum profundus. Both of these are finger flexors, but superficialis is only going to end at the pip joint. So it does not cross over to dip, meaning it's going to end at that second knuckle. Profundus is deep. So it is going to go all the way to the end, which means it goes to the dip joint. And it kind of makes sense because you can't have a superficial muscle go farther than the deep muscle. They wouldn't stack correctly like that. You would experience too much active insufficiency for that to happen. You have to, when you're making a building, your foundation is the usually widest part of the building, right? And then when you get to the top, it's usually the narrowest. Other than for like, say, aesthetics or having like, say, something like a functional purpose, like a lightning rod. You look at like a skyscraper and you don't have a needle at the bottom, right? You have wide to small. So with your muscles, you have superficial being essentially that needle. It goes smaller or shorter. Deep is going to be your more base. It's going to be more distal. So anything that's deep is going to have a more distal action on your muscle or on your joint area than superficial will. That kind of makes sense? Now, hopefully you don't get confused with the pronators and supinator. Those are pretty easy to tell you what they do. Now, anytime you cross over a joint, you are going to move that joint. This is why, for example, your biceps is important relative to your shoulder because your long head of your biceps inserts on the superior labrum. So your biceps are going to contribute to arm flexion because they cross over this shoulder joint. Main function of biceps and triceps is to manipulate the elbow. So biceps flexes, triceps extends, but both of them cross over the shoulder, so both of them are going to assist in that movement. When we talk about the calves, the main difference between gastrocs and soleus is gastrocs is going to originate on your distal femur. Soleus originates on the tibia and partially the fibula. Then they both come together to a common insertion point known as the what?
Achilles.
Yes, Achilles or calcaneal tendon. Very good. So soleus will not move the knee. Gastrocs will. Same thing with our, really any of our wrist forearm muscles here. Now, I did tell you to remember the keywords. So like digit means fingers. They also carry, depending on where their insertion point is, or I'm sorry, their origin point is, they're going to move potentially more stuff. So flexor digitorum superficialis, main purpose of this is to flex your fingers. So the name tells you its primary role. Primary role, think of that as your agonistic role. Wherever that muscle crosses over a joint, it's going to at least assist in that movement. So flexor digitorum superficialis, this is going to assist with wrist flexion, and it also will assist a little bit with elbow flexion. So y'all see why that is. It's not much, but it's honest work. So while you should be aware of that, just also remember that the name of the muscle is what your agonist movement or prime moving target is going to be. You may see the term thenar talking about the thumb as well. So if you see that, don't be alarmed. But again, in terms of musculature, main word we're looking for is pollicis. So your flexor pollicis is going to flex your thumb. Extensor is going to extend the thumb. Your hand extensors, outside of the thumb, which extension is that way, any of your finger extensors really aren't going to do a whole heck of a lot. You have the most extension movement with your MCP joint. So, I mean, everyone can move their MCP joint in extension, hopefully. Extension of the dip and pip joints is really non-existent. Now, I say that, and then I can do this with my index finger where I go into hyperextension with that. That's not normal. I broke one of these a couple times. So whatever. But yeah, probably shouldn't be able to do that. So you have, full extension, which is really all you need. It's kind of like with your knee. I mean, how many of you have a need to bend your knee backwards kind of thing? I mean, if you were a flamingo, absolutely. But since none of us are pink and we can't fly, unfortunately, that is not needed. The least amount of movement you have and the least amount of controllable movement you have is with the dip joint. So unless you go out of your way to isolate the dip joint, it's very hard to move that on its own. I say that and then I can do this. So again, this index finger is like just, something that's been through the gauntlet, so now has superpowers. When you move your dip joint, you usually have to isolate it by holding onto the pip joint, so then you can then move that dip. So this again is that issue of active insufficiency. You're not able to move the distal joint without the movement of the proximal joint. So if you cut off, though, the proximal joint, it only leaves the distal joint to move. All right, and I want to kind of finish up here with our grips and good stuff here. So like I said, you've all been over this, so it should be just kind of review for you here. Power grips are all for gross motor skills. Precision grips are all for fine motor skills. This also carries, especially the power grip side, carries a practical implication in terms of say training, like resistance training. So you look at your 4 different grips here. The hook grip is your main lifting grip for large objects. Hook grip doesn't use the thumb, so you just hook the fingers kind of thing. And if you think about it, if you lift, say a box, if I'm lifting a box, can I take my thumb and cross over or grasp the box? No, you can't. So that's where hook grip is going to come into play. Well, when you use your thumb, remember your muscle groups that you're moving here. But anyways, if you hold on to say your forearm and then you just move your thumb, you should feel at least a little bit of movement in your proximal forearm. So you should feel some flexion going on there, right? Or am I just the only one that can do that? I mean, do you all feel something? Okay. Now, when you're, say, doing any kind of bar, dumbbell-based lifting, you usually hold your thumb over, right? You form that nice little fist grip bit. If I were to modify those to be a hook grip, what do you think is going to happen? So easiest example, I'm doing a lat pull down. You've all seen that before, right? Okay, lat pull down, I hold the bar with typically a fist grip kind of thing. Pull down, whatever. What happens if I take my thumb and turn this into a hook grip by taking my thumb off and around that? So instead of, having it like this, I now have it like this. What does that change in terms of the muscles I'm using?
You're not using your thumb muscles.
No, so what does that then mean?
You're working all of these flexors harder.
Yeah, specifically your wrist flexors are going a lot harder. I mean, your finger flexors and intrinsic hand muscles are going to get strengthened no matter what because you have to grip something. But this is an example of where you can kind of kill two stones with one bird. As I asked earlier, how many of you do wrist curls, wrist extensions, and got a whole whopping one of you to respond in the affirmative there. If you still want to train your forearm muscles, but you don't really want to do it, changing to a hook grip is going to force more forearm muscle activation than if you have a fist grip. And it's all because you're forcing more activation of the actual wrist flexor extensor muscles because you get rid of the pretty powerful thumb muscles. Can that make sense? Now, with your cylindrical and spherical grip, I mean, these are pretty self-explanatory, but the main thing with them is that they don't have the thumb cross over the fingers. So hook grip, no thumb at all. Cylindrical, spherical grip, no contact between the thumb and the fingers. Fist grip, you do. And I don't want to teach you all to say fight and whatnot, but if you ever find yourself trying to punch someone or something, never put your thumb in your hand. That is a very quick way to, break your thumb kind of thing. We'll talk about boxers' fractures here in a little bit, but yeah, just, your FF fun fact for the day. Pretty much spherical and cylindrical grips are pretty well interchangeable. For all intents and purposes, it's the same thing. It's just relative to the object you're manipulating. The point, though, that you should remember is that, again, hook grip, no thumb. Fist grip, thumb touches the fingers. Cylindrical, spherical, thumb does not touch the fingers. And power grips are all gross motor skills. Now, don't confuse something like, say, the way they show the hook grip or the way they're showing a cylindrical grip with our precision-based grips. Because if I am, say, throwing a ball, that is a precision movement. Now, granted, I guess I could theoretically just grab a ball, with my whole hand and throw it. That would be more gross motor, I guess. But when you say throw a ball or for the most part do any of these precision grips, primarily the three-prong chuck is, the three-prong chuck is your most useful grip because this is the one that incorporates at least 3 fingers. So you think about it, using your nice claw here, you can do virtually anything you want aside from say throw a football. So if we take rank all of our fingers in terms of importance, thumb's number 1, index finger's number 2, arguably middle finger's number 3 for both, communication and for function. And then pinky is number 4. Ring finger, for the most part, is absolutely useless unless you are, engaged and or getting married. And you think about it, what do you actually use your ring finger for?
A ring.
Yeah, that's about it. So I just got a free life insurance policy from my car company for a whopping $2,000. And I was reading kind of the fine print of it, and I don't even have to die to get a payout, which is kind of awesome. I mean, yeah, $2,000, whatever. But I mean, it's free, why not? I only need 2 of the following to happen: losing an eye, a limb, a finger, a thumb, or a foot. If I just lose 2 of the following, I get this nice $2,000 payout. So anybody got a knife handy? I got 2 ring fingers that don't really need anything. No, my wife is already not happy with me because I never wear my ring. Not like I'm trying to do anything nefarious, but I just do not like jewelry. I don't like metal touching my skin kind of thing. Never really into that. So I wore it for our wedding day and I wear it for like our anniversary, and that's about it. Oh, that's so sad. I should wear it more because I have the ring I have is the replica Black Panther ring. So it's the one that Chadwick Boseman wore, and now he's dead. So T's and P's. Now, with our 2 different types of pinches here, your lateral and your tip to tip, this just matters where you're touching your index finger. So you're using the pad of your thumb for both of these, but if I touch the side of my index finger versus the pad of my index finger, we'll just distinguish which one I'm using. Your lateral pinch, not a whole lot of use for that. I mean, they show here holding your car keys. That's really about it. You could argue maybe like holding a writing utensil, but for the most part, that's gonna be a 3-prong chuck thing. So your tip to tip and your 3-prong chuck, those are the 2 most useful precision grips you have. The other thing that really is never mentioned here, which clearly this person does not have a problem with, is your nails. How many of you can pick up a penny from the ground if you don't have nails? I mean, it's very difficult to do it. Or, crack open a pop tab. Yeah, kind of difficult without nails there. So when you think about doing a lot of the tip to tip pinch grips, you also got to consider that you need something to lift the surface, especially if you're small objects, to actually make it work. I've said it before, I really enjoy the fact that we don't have any game day parking anymore, because I don't have to worry about parking off campus and forcing myself into extra physical activity that I don't want to do. But God, I just cannot wait to get rid of these masks. I mean, have any of you ever tried to open a produce bag without licking your fingers? And seriously, I don't want to be that guy that sticks my hand underneath my mask in my face and then goes and does that, even though I really want to. So usually I just wait till my kid decides to start whatever, acting up, and then I'll stick a finger in his mouth. Yeah, he turns 2 in 2 weeks. And when he was first born in 2019, God, that was a terrible time to be born. His whole life, he has only known just pandemic. Good Lord. Anyway, I remember I was teaching this class in the summer of 2019, and the day before class started, fucker sneezed in my mouth. got me sick. So everyone complained on the first day of the dean that they couldn't hear me. And then I had to cancel class the next day. And I got another complaint because someone from Mesa didn't get the memo and showed up. But yeah, cute kid though. Ooh, this page is not aged well. Ooh. Let's go ahead and skip that one there. All right, you have arches in your hand, similar to you have arches in your feet. The arches in your hand aren't really all that important. I mean, they're not important because you don't weight bear on your hands. I mean, if any of you, I guess, were walking on your hands like all day, okay, you win. But they're not so important because you don't do weight-bearing activities on your hands. Feet, on the other hand, I mean, stand on your feet a ton of time during the day, so you have to support your entire body weight on there, so the arches of your feet are much more important. You have the same exact setup with the arches of your hand as you do your feet. However, there's only really 2 arches in your hand, so you only have really 1 transverse arch and 1 longitudinal arch, whereas with your feet, you have 2 longitudinal arches and you have 1 transverse arch. This just really helps to keep more stability to both areas. Now, the carpal tunnel. The carpal tunnel is obviously in your wrist, so carpal meaning wrist. If you take your thumb and your index finger, or in your middle finger, and you hold them around your wrist, that gives you approximately the size or the circumference of what your wrist is. So keep that in mind. If we look, this here is our carpal tunnel. And you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 things going in there. So again, there's your wrist circumference. Fit 10 of anything through there, right? Oh, but by the way, the carpal tunnel itself is only about that big. So that's how much space you got, like roughly a little bit less than a quarter size to fit 10 things in there. Now, you have this nice sheath going around here to keep everything all nice and snug. And you do have everything being separated by connective tissue. So it's not as though it's like truly rubbing all up against each other, but you're in a very close proximity. Your carpal tunnel is not aware at all of social distancing. So if any of these ever get inflamed, you can see how it can cause quite rapidly a domino effect here. None of these really matter. Because why? What's left? Yes, this guy right here, your median nerve. If you get any kind of tendonitis or whatnot, I mean, yeah, that's bothersome, but whatever. You injure a nerve, now you're talking about losing function. And you're possibly talking about being in, like, say, constant pain. You know, you see like the commercials for, like, say, peripheral neuropathy or diabetic nerve pain and that kind of stuff. Anybody know, other than the United States, what's the only country that allows pharmaceutical advertisements to be shown to the general public? Our good old friends, the New Zealanders. So us in New Zealand are the only ones that allow you to advertised to the public for pharmaceuticals. And I never got it why. I mean, how many of you have gone to your doctor and said, I want, this name brand drug for a condition that I hope you're going to test me for, and I come back positive with it. So anyways, with your nerves, especially with the forearm and hand nerves, you come down off the brachial plexus, axillary nerve splits into three. Three nerves we have coming down our forearm and into our hand: ulnar nerve, radial nerve, median nerve. So ulnar nerve, ulnar side, makes sense. Radial nerve, radial side, makes sense. Median nerve, median middle, goes right there. Your ulnar nerve is going to control your pinky and the outer half of your ring finger. Your radial nerve controls your thumb and the outer half of your index finger. Then your median nerve controls the entire center of your palm, your middle finger, and the insides of your ring and index fingers. It has the most amount of surface area to control. Granted, it's not the most functional because, theoretically, if I lose my index finger, my middle finger, there we go, things could be worse. I could lose my thumb. That'd be really bad. Whenever you put pressure on this, and the way that this is being shown is that you are in an anatomical position here. So your carpal tunnel is in front of, or I guess kind of anterior to your carpal bones. If you get any pressure on there, it's something that's going to happen with repetitive or usually overuse movement. You really don't get carpal tunnel syndrome from, like, say, trauma or like an accident injury. You can, get in a terrible car wreck and you could end up with that. You probably have a lot other problems though that you need to worry about other than that. But whenever you are doing overuse movements with your hands, that's where you're most susceptible to having some sort of injury to this. Who do you think, what kind of populations are most susceptible, do you think, to carpal tunnel syndrome? Two main groups primarily. So people who in general are doing a whole lot of typing or like have desk jobs, the more your wrists are in flexion and you're manipulating them, the more you are going to put stress on that carpal tunnel. And the other one is manual laborers, especially people who are, swinging around objects like hammers, axes, that kind of thing. Hammers are especially bad because you have that whole vibrational force that you get from an impact. So if I hit a nail with a hammer, remember Newton's third law, equal and opposite forces, that force I hit with the hammer is coming back up the hammer. Now, granted, because I have a hammer, it's not directly impacting me, but the vibration of the hammer is going to impact me. It's like if you ever played baseball or softball and you hit the ball on the inside part of the barrel, it causes a stinger in your hand because the bat vibrates at a frequency that your hand does not like. And if you looked at it on like really super slow motion, you would see the bat actually vibrating, and it's kind of freaky, but all of that vibrational force comes back on you. So doing that repetitively is kind of the worst thing you can do for your wrists. The problem or the main issue with, say, carpal tunnel syndrome is that you get it from overuse. So if your job involved doing the thing that gave you carpal tunnel syndrome, how likely are you to be able to stop doing that thing? Yeah. And anytime you have any nerve or tendon issue, it's going to take a while to heal. It's not like, say, a broken bone where you put it in a cast and you're all good to go, because you most likely aren't going to break a bone again if you don't do whatever you did to break the bone. you really can't avoid, especially if your, career profession requires you to, doing that thing and still, stay in that career. So it's one of those things that it's very annoying. I mean, it's not going to kill you by any means, but it can potentially be debilitating in its later stages. You could lose a lot of function in the hand overall if you were to, like, say, keep using the wrist hand while it was injured and didn't modify anything. I mean, if you think about, like, say, a baseball pitcher, how many baseball pitchers that get, like, say, rotator cuff tendonitis, do you see them keep pitching? I mean, you stop, right? You recover or you rehab. You don't just say, yeah, I mean, my shoulder hurts, I'm just going to keep going at it, So that's the main problem you have there. And I talked about that already. Don't worry about all these different activities and what kind of injuries you can have. Any of the ones that we talked about specifically in class, those are the ones that we're going to be kind of more concerned with. Now, there are a couple here that we want to mention. Forearm fractures. These are almost exclusive to, like, say, a blunt force trauma kind of thing. You're usually not going to injure the forearm independently of the wrist or the shoulder clavicle or elbow by falling on it. Usually it's like an impact injury kind of thing, like you hit it specifically. These are rare-ish. The boxer's fracture here. This is a fracture in the 4th and 5th metacarpal. So I forgot to mention that when you are talking about labeling your metacarpals and your phalanges, you label them based on numbers. So thumb is 1, pinky's 5. So boxer's fracture occurs in typically the 4th and 5th metacarpal. And it comes just from the impact of punching something, someone. If you want to avoid that, hammer fist. So I wouldn't go picking fights, but at the same time, just know if you're ever going to, be forced into something where you have to hit something, don't hit it with your fist, unless you're kind of trained. Boxers are usually pretty decent at that. But hammer fist, that's the easiest way to get around it. No matter what, don't hit anyone in the skull either. Like, anything that protects your brain has got to be pretty sturdy. So yeah, pretty much one of the hardest parts on the body is the skull itself. So unless you're using an object, God, don't do that though. Yeah, don't hit anyone in the head. Keep to soft tissue. You want to, work the kidneys, get the, the body blows going. Oh, this is terrible. What am I doing with my life? I don't know if this message is, like, good or bad. I still have, like, conflicting thoughts on it, but while in no way do I advocate, like, say, abusing animals or harming animals. If anyone does, and I'll use the term very loosely, correct animal behavior, you should never hit them anywhere except their head. You would think that's kind of counterintuitive, but for example, like a dog has roughly a skull that's roughly twice as thick as ours. It's essentially like they're wearing a football helmet at all times. Don't ever hit a dog in their body, because that can very easily injure them badly. So again, I don't know if, like, this PSA is good or not, but while I don't at all advocate for harming your animals, like I said, if someone hits an animal, first off, you're a shitty human being, but if you're gonna do it, at least hit them in the head so that they don't, die kind of thing. I don't know, is that good or bad? I mean, should I have told you that? A little late now, but. All right, your carpal fractures, scaphoid and trapezium can get injured kind of frequently. And the other one that you'll see here is, well, not that. It would be an avulsion injury, but on the pisiform, you can see that happen. Typically, if you fall onto an extended wrist, you are at risk for fracturing either side of the wrist. So that can happen. The skier's thumb or gamekeeper's thumb, this is just when you get your thumb caught on something and you essentially pull it into kind of a hyperextension. That can just injure the ligaments around the thumb. Not fun, but it doesn't happen too much.
Happens to football linemen a lot.
Yeah, that is true. This avulsion injury is somewhat common. I mean, when you're injuring, like, say, a finger, I mean, yeah, you can like stub a finger or whatnot, but you're usually not injuring, like, say, your finger, wrist, hand without some sort of, pretty serious impact. Aside from, like, say, getting a digit caught in something, the impact you're going to see is usually going to be something that hits you from the front. You really get anything pulling back that's going to do it. I mean, yeah, if you say, like, got your fingers caught and pushed your hand forward, that's going to be problematic. I remember when I was coaching baseball, I was coaching a 13-year-old team years ago, and kid slides into third head first, and I still don't even know how he completely did it, but he slid in head first to third. He's safe, but he bent his fingers back on the base, and I believe his ring finger, his MCP joint popped out completely. And you got to say, your bones are like the most pearly white things you would ever see. I mean, ignore like the blood and all that, but yeah, bones themselves, like the whitest of white things, like those fake porcelain bleached teeth. That's what your bones look like. What was kind of, funny for a second is we're all horrified because we're in the third base dugouts. We see this all happening real time. Kid gets up and he like claps his hands. Like, he's pumped. And then he sees, like, oh, perfectly fine though. Like, 13-year-old kid, nothing wrong, right? Obviously, his dad freaks out. We're all freaking out because, you can see this from a mile away. So they get up to leave, obviously got to go have surgery now. As soon as he hits the parking lot, I hear like this shriek of a scream that's like still haunting to this day when the adrenaline finally wore off. And yeah, so eventually that's going to come get you. But for the most part, yeah, kind of hard to injure your fingers unless you have some sort of impact to them. These avulsion injuries are where you have essentially an injury to a tendon or ligament, but not really. A typical sprain, I should say, is when you tear your tendon or ligament. If you were to tear a tendon or ligament, but the ligament or tendon stays intact, but pulls off a chunk of bone with it, that's your avulsion injury. So this top one here is your typical, like a grade 3 sprain. You sprain a ligament or tendon, you strain a muscle. Both are referring to tearing it. But this is a typical grade 3 sprain where this would like cut completely in half. Full thickness tear would be another word for it. Avulsion means that this connective tissue is perfectly fine, but it rips out part of the bone to which it was inserted. You usually don't see these happen on the origin points because your origin tends to be much more stable. You're going to see it much more on the insertion points. these are almost exclusive to your ankle, foot, wrist, and hand. Very hard to have an avulsion injury with the bigger ones because the bones are a lot stronger. All right, mallet finger, this would be if you had an injury here to your flexor digitorum profundus, there we go. This here is, whoops. This really isn't an elbow dislocation. This would most likely be a bad bursitis. So remember we talked about bursitis or in your bursisacs. Your bursisacs are essentially kind of like a lubricant cushion around a lot of your synovial joints. This is what happens when it gets all inflamed. Dislocation here. You notice how it doesn't really look that bad. I mean, relatively speaking. If you were to just look at this arm like this, would you really even suspect anything's wrong? I mean, not particularly. I mean, yeah, if you're trained, obviously you're going to scrutinize everything. But if you can see the x-ray, I mean, that looks relatively normal. And it's all because when you have a closed injury like that, so like, you know, bone's not sticking out of the skin, there's not a whole lot of movement that occurs there. I mean, yes, this is definitely painful and all that good stuff, but still. Tennis elbow or little league elbow, that's where you're going to get tendonitis in your upper forearm elbow area. Dislocations, usually these occur from an impact directly to the tip of the finger. This here's a ganglion cyst. These are pretty much exclusive to like your wrist. You don't really see them anywhere else. Anyways, unlike a typical cyst, like a water or fluid-filled cyst or anything like that, these are deep. So these are actually underneath. You can see kind of all the musculature around here. So you can't just like, you know, go to Dr. Pimple Popper and get her to cut that out, because you actually have to go underneath all your musculature. With any cyst, if you don't get the cyst sac out, it'll regrow. So that's why you'd have to actually get that fully extracted. Usually nothing is done about these unless they're symptomatic. So yeah, while this cosmetically doesn't look perfect, if it's not causing any issues in terms of function or pain, there's no real benefit to actually getting it taken out. All right, and that is about everything I had for you there with the wrist and hand. What kind of questions do you all have? All right, well, if you all don't have any other questions, you guys are all good to go. So let's you out a few minutes early here. So thank you all for getting through all this with me. And then I will see you all hopefully next week.